Advanced techniques of general anesthesia. Expanded lecture notes. As anesthesia continues to evolve, advanced techniques have emerged to improve patient outcomes, enhance surgical conditions, and reduce complications. From total intravenous anesthesia to advanced ventilation strategies, these techniques require a deep understanding of pharmacology, physiology, and technology. In this lecture, we'll explore the latest advancements in general anesthesia, discussing their benefits, risks, and applications in modern anesthetic practice. Advanced techniques of general anesthesia. 1. Balanced anesthesia. 1. Combination of agents. Balanced anesthesia involves using multiple agents to achieve the goals of general anesthesia while minimizing side effects. 2. Example: IV induction propofol plus opioid fentanyl plus muscle relaxant rocuronium plus inhalational agent sevoflurane. This combination provides a balanced approach to anesthesia, utilizing the benefits of each agent. 2. Total intravenous anesthesia TIVA. 1. Only IV agents used. TIVA involves using only intravenous agents, such as propofol and remifentanil, to maintain anesthesia. 2. Advantages: stable hemodynamics, less PONV, no exposure to inhalational gases. TIVA offers several benefits, including stable blood pressure, reduced postoperative nausea and vomiting, and avoidance of inhalational gases. 3. Limitations: requires infusion technology, careful dosing. TIVA requires specialized equipment and careful dosing to ensure safe and effective anesthesia. 3. Inhalational anesthesia. 1. Maintenance with volatile agents. Inhalational anesthesia involves using volatile agents, such as sevoflurane and desflurane, to maintain anesthesia. 2. Induction mainly in pediatrics. Inhalational induction is often used in pediatric patients due to their tolerance and ease of use. 3. Useful for bronchodilation. Asthmatics. Volatile agents can provide bronchodilation, making them beneficial for patients with asthma. 4. Neuroleptic anesthesia. 1. Use of neuroleptic plus opioid. Neuroleptic anesthesia involves combining a neuroleptic agent with an opioid to provide anesthesia. 2. Historical, less common today. This technique is less commonly used today due to the development of newer anesthetic agents and techniques. 5. Combined techniques. 1. GA plus regional. Combined techniques involve using general anesthesia with regional anesthesia, such as epidural anesthesia, to provide better pain relief and reduce general anesthesia requirements. 2. Provides better analgesia, reduces GA requirements. This approach can provide excellent pain relief and reduce the need for general anesthetic agents, minimizing side effects. Preoperative assessment for general anesthesia. 1. History. 1. Medical conditions. Assessing medical conditions such as cardiac, respiratory, renal, hepatic, and endocrine diseases helps identify potential risks and develop an anesthetic plan. 2. Previous anesthetic history. Knowing previous anesthetic experiences, including complications and malignant hyperthermia, is crucial for planning safe anesthesia. 3. Drug allergy history. Understanding a patient's medication history and allergies helps avoid potential interactions and allergic reactions. 4. Last meal NPO status. Verifying a patient's fasting status is essential to reduce the risk of aspiration during anesthesia. 2. Examination. 1. Airway assessment. Evaluating the airway using tools like the Mallampati score, thyromental distance, and neck mobility helps predict potential difficulties with intubation. 2. Cardiovascular, respiratory, neurological, other system exams. A thorough physical examination assesses the patient's overall health and identifies potential risks. 3. Investigations. 1. CBC, electrolytes, renal liver function, Laboratory tests help identify abnormalities that may impact anesthesia or surgery. 2. ECG, chest X-ray if indicated. Additional tests, such as ECG and chest X-ray, may be necessary based on the patient's medical history and physical examination. 4. ASA classification. 1. ASA-I, healthy patient, patients with no significant medical conditions. 2. ASA-II, mild systemic disease, patients with mild diseases that do not significantly impact daily life. 3. ASA-III, severe systemic disease, not incapacitating, patients with severe diseases that impact daily life but are not immediately life-threatening. 4. ASA-IV, severe systemic disease, constant threat to life, patients with severe diseases that pose a constant threat to their life. 5. ASA-V, moribund patient, not expected to survive without operation, patients who are critically ill and may not survive without surgery. 6. ASA-V, brain dead, for organ donation, patients who have been declared brain dead and are undergoing surgery for organ donation. Premedication for general anesthesia. 1. Anxiolytics. 1. Benzodiazepines, midazolam, diazepam. These medications help reduce anxiety and promote relaxation before surgery. 2. Analgesics. 1. Opioids, morphine, fentanyl. Opioids provide pain relief and can help reduce the stress response to surgery. 2. NSAIDs, nonsteroidal anti-inflammatory drugs, can also provide analgesia and reduce opioid requirements. 3. Anesthesiologists. 1. Tropine, glycopyrrolate. These medications reduce secretions, making it easier to manage the airway during anesthesia. 4. Antiemetics. 1. Ondansetron, metoclopramide. Antiemetics help prevent postoperative nausea and vomiting, improving patient comfort and reducing complications. 5. Antacids, H blockers, PPI. 1. Antacids, H blockers, and proton pump inhibitors, PPIs, reduce stomach acid and help prevent aspiration pneumonia by decreasing the risk of aspiration of acidic gas contents. These premedications help ensure a smoother anesthetic experience and reduce the risk of complications. Airway management under general anesthesia. 1. Basic airway management. 1. Face mask provides a means to deliver oxygen and anesthetic gases to the patient. 2. Oral nasal airway helps maintain a patent airway by preventing obstruction from the tongue or soft tissues. 2. Definitive airway management. 1. Endotracheal intubation, ETT, involves placing a tube into the trachea to secure the airway and provide a reliable means of ventilation. 2. Supraglottic airway device, LMA, sits above the glottis, providing a seal around the laryngeal inlet to facilitate ventilation. 3. Advanced airway management. 1. Fiber optic intubation utilizes a flexible fiber optic scope to visualize the airway and facilitate intubation, often used in difficult airway situations. 2. Video laryngoscopy employs a video camera embedded in the laryngoscope blade to enhance visualization of the airway, aiding in intubation. 4. Emergency airway management. 1. Cricothyrotomy, an emergency procedure involving an incision in the cricothyroid membrane to establish an airway when other methods fail. 2. Tracheostomy, a surgical procedure to create an airway by making an opening in the trachea, often performed in critical situations or for long-term airway management. Drug details in general anesthesia. 1. Intravenous induction agents. 1. Propofol, rapid onset and smooth induction make it a popular choice. It also has antiemetic properties. However, it can cause hypotension and respiratory depression. 2. Thiopentone, a barbiturate with rapid onset. Thiopentone is effective for induction. Side effects include respiratory depression, hypotension, and potential issues in patients with porphyria. 3. Etomidate, known for its hemodynamic stability. Etomidate is useful in patients with cardiovascular instability. However, it can cause adrenal suppression and myoclonus. 4. Ketamine provides dissociative anesthesia with preserved analgesia. Side effects include hallucinations, increased heart rate and blood pressure, and bronchodilation. 2. Inhalational agents. 1. Sevoflurane. With rapid onset and a non-irritant profile, sevoflurane is often preferred in pediatric anesthesia. 2. Desflurane. Characterized by very rapid onset and offset, desflurane is useful for quick recovery. However, it can be an airway irritant. 3. Isoflurane. A potent and inexpensive agent, isoflurane is suitable for long surgeries. 4. Halothane. Although potent, halothane carries risks of hepatitis and arrhythmias, limiting its use. 5. Nitrous oxide provides analgesia and is used as an adjunct to other anesthetics. It is a weak anesthetic agent. 3. Muscle relaxants. 1. Depolarizing. Succinylcholine, rapid onset and short duration make it ideal for rapid sequence intubation, RSI. However, it can cause hyperkalemia, malignant hyperthermia, and bradycardia. 2. Non-depolarizing. Rocuronium, vicuronium, atracurium. These agents provide muscle relaxation and can be reversed with neostigmine or sigamidex, specific to rocuronium and vicuronium. 4. Opioids. 1. Fentanyl, remifentanil, morphine. Opioids provide effective analgesia and reduce anesthetic requirements. Side effects include respiratory depression and chest wall rigidity. Remifentanil is notable for its short duration of action. Special considerations in general anesthesia. 1. Emergency surgery. 1. Rapid sequence induction, RSI, a technique used to quickly secure the airway and minimize the risk of aspiration in emergency situations. 2. Cricoid pressure, Sellick's maneuver, applying pressure to the cricoid cartilage helps prevent gastric aspiration during intubation. 3. Avoid delay. Prompt action is crucial to reduce the risk of aspiration and ensure timely surgical intervention. 2. Obstetrics. 1. Decreased functional residual capacity. Pregnant women experience changes in lung function that can affect anesthesia management. 2. Increased aspiration risk. The risk of aspiration is higher in pregnant women, making RSI a staggered approach. 3. Avoid teratogenic drugs. Careful selection of anesthetic agents is necessary to avoid potential harm to the fetus. 3. Pediatrics. 1. Inhalational induction preferred. Inhalational induction is often preferred in pediatric patients due to their tolerance and ease of use. 2. High risk of laryngospasm. Pediatric patients are more susceptible to laryngospasm, requiring full airway management. 3. Careful fluid and temperature control. Pediatric patients require close monitoring of fluid balance and temperature to prevent complications. 4. Elderly. 1. Increased sensitivity to drugs. Older adults may be more sensitive to anesthetic agents, requiring careful dosing. 2. Slower metabolism and elimination. Age-related changes in drug metabolism and elimination can affect the duration of anesthesia. 3. Reduced cardiovascular reserve. Elderly patients often have reduced cardiovascular reserve, making them more susceptible to hemodynamic instability during anesthesia. Post-anesthesia care (PACU) recovery room. 1. Airway management. 1. Ensure patency. Maintaining a patent airway is crucial for adequate oxygenation and ventilation. 2. Suction if needed. Suctioning helps remove secretions and maintain airway patency. 2. Breathing support. 1. Oxygen supplementation. Providing supplemental oxygen helps ensure adequate oxygenation. 2. Monitor SPO. Continuous monitoring of oxygen saturation helps identify any issues with oxygenation. 3. Circulation monitoring. 1. Monitor HR, BP, perfusion. Close monitoring of heart rate, blood pressure, and perfusion helps identify any cardiovascular issues. 4. Consciousness assessment. 1. Assess level of recovery. Evaluating the patient's level of consciousness and recovery helps determine readiness for discharge from the PACU. 5. Pain and nausea management. 1. Adequate analgesia. Providing effective pain relief is essential for patient comfort and reducing stress. 2. Antiemetics. Administering antiemetics helps prevent and treat postoperative nausea and vomiting (PONV). 6. Complication monitoring. 1. Laryngospasm. Monitoring for laryngospasm, a sudden closure of the vocal cords, is crucial. 2. Airway obstruction. Identifying and managing airway obstruction is essential for patient safety. 3. Hypoxia. Monitoring for hypoxia and providing supplemental oxygen as needed helps prevent complications. 4. PONV. Managing postoperative nausea and vomiting is important for patient comfort and reducing complications. 5. Shivering. Shivering can be a sign of hypothermia or stress, and managing it helps maintain patient comfort and prevent complications. Common complications of general anesthesia. GA. 1. Airway and respiratory complications. 1. Hypoxia. Insufficient oxygen levels can lead to serious complications, including organ damage and brain injury. 2. Hypercarbia. Elevated O levels can cause respiratory acidosis and other complications. 3. Laryngospasm. Sudden closure of the vocal cords can obstruct the airway and make ventilation difficult. 4. Bronchospasm. Constriction of the airways can make ventilation challenging and lead to respiratory complications. 5. Aspiration. Inhalation of gastric contents into the lungs can cause severe respiratory complications, including pneumonia. 2. Cardiovascular complications. 1. Hypotension. Low blood pressure can lead to inadequate perfusion of vital organs and potential organ damage. 2. Arrhythmias. Abnormal heart rhythms can compromise cardiac function and lead to serious complications. 3. Myocardial depression. Decreased cardiac function can lead to inadequate perfusion and potential cardiac complications. 3. Neurological complications. 1. Awareness during anesthesia. Patients may experience awareness or recall during surgery, which can be distressing. 2. Delayed emergence. Patients may take longer than expected to recover from anesthesia, potentially due to various factors. 3. Postoperative cognitive dysfunction. Some patients may experience cognitive impairment or memory issues after surgery. 4. Metabolic complications. 1. Malignant hyperthermia, a rare genetic disorder triggered by certain anesthetic agents, including succinylcholine and volatile agents. Signs include hypercapnia, tachycardia, rigidity, and hyperthermia. Treatment involves administering dantrolene IV. 5. Postoperative complications. 1. Nausea and vomiting (PONV), a common complication that can lead to dehydration, electrolyte imbalance, and patient discomfort. 2. Shivering. Shivering can be a sign of hypothermia or stress, and managing it helps maintain patient comfort. 3. Sore throat, a common complaint after surgery, often due to intubation or airway manipulation. 4. Agitation. Patients may experience agitation or restlessness after surgery, potentially due to pain, discomfort, or other factors. Anesthesia safety and checklist. 1. WHO Surgical Safety Checklist. 1. Timeout before incision, a critical step to confirm patient identity, procedure, and sight, ensuring patient safety and preventing errors. 2. Pre-induction check. 1. Anesthesia machine and equipment check. Verifying the functionality of anesthesia equipment helps ensure safe anesthesia delivery and prevents equipment-related complications. 3. Monitoring standards. 1. Meet minimum ASA standards. Adhere to established monitoring standards, such as ECG, SPO, and blood pressure monitoring, helps ensure patient safety during anesthesia. 4. Emergency preparedness. 1. Emergency drugs readily available. Having essential emergency medication, such as atropine, adrenaline, ephedrine, and succinylcholine, readily available helps ensure prompt response to critical situations and patient safety. General anesthesia exam and OSCE points. 1. Definition of general anesthesia. 1. Reversible drug-induced unconsciousness. General anesthesia induces a state of controlled unconsciousness, allowing patients to undergo surgery without awareness or pain. 2. Analgesia, amnesia, and muscle relaxation. General anesthesia provides pain relief, memory loss, and muscle relaxation, ensuring a comfortable and safe surgical experience. 2. Stages of anesthesia. 1. Gettel's classification, a historical classification system that describes the stages of anesthesia, from analgesia to overdose. 3. Drugs for induction. 1. Propofol, a commonly used induction agent known for its rapid onset and smooth induction. 2. Thiopentone, a barbiturate used for induction, providing rapid onset of anesthesia. 3. Etomidate, an induction agent that provides hemodynamic stability, making it suitable for patients with cardiovascular instability. 4. Ketamine, an agent that provides dissociative anesthesia, analgesia, and amnesia, with preserved airway reflexes. 4. Airway management. 1. Mask ventilation, a technique used to provide oxygenation and ventilation during anesthesia. 2. Intubation, insertion of an endotracheal tube to secure the airway and ensure safe ventilation. 3. LMA, laryngeal mask airway, a device that sits above the glottis, providing a seal around the laryngeal inlet to facilitate ventilation. 5. Complications of general anesthesia. 1. Awareness. Patients may experience awareness or recall during surgery, which can be distressing. 2. Aspiration, inhalation of gastric contents into the lungs can cause severe respiratory complications. 3. Malignant hyperthermia, a rare genetic disorder triggered by certain anesthetic agents, requiring prompt treatment with dantrolene. 6. Special considerations. 1. Pediatrics. Anesthetic management in pediatric patients requires consideration of their unique physiology and anatomy. 2. Elderly. Older adults may require adjusted anesthetic dosing and careful management due to age-related changes in physiology. 3. Pregnancy. Anesthetic management during pregnancy requires consideration of the mother's and fetus's unique needs and potential risks. 4. Emergencies. Anesthetic management in emergency situations requires prompt action, careful planning, and consideration of the patient's condition and potential risks. Thank you for watching. If you liked this content, don't forget to like to show your support, comment and share your thoughts. Share with your friends and family. Subscribe for more exciting content. Your engagement means the world to us. Stay tuned for more.